So I will be speaking on PRP in osteoarthritis. So platelet has been known for time immemorial for last 120 years to us, as a which is responsible for blood clots, or when the bleeding happens, the bleeding stops because of platelets. For last 20, 25, 30 years, then people started realizing that platelets have some other very big role in the form of, it has a lot of growth factors in the form of PDGF, EGF, FGF, and VGF, TGF beta, etc., etc. All these growth platelets are a storehouse of all these growth factors. So what these growth factors, once you give platelets to a tissue or inject a platelet to this tissue, this platelets get activated and release these growth factors, and these growth factors have effect on almost all the tissues: osteoblasts, chondrocytes, mesenchymal stem cells, fibroblasts, endothelial cells, and result in proliferation of these things and angiogenesis, and also helps in remodeling. A lot of ex vivo in vitro studies have very clearly shown that platelets have these growth factors, and growth factors work in culture media. That's how the platelet-rich plasma came into picture. So if you look at the history, it is not very far away. 1980s and 1990s, people started using PRP for ulcers first. Then happened in 1987, they used in open heart surgeries for wound healing. Then 1990s for maxillofacial surgeries. And 2000 and 2006, last 15-20 years, is the time when people started using PRP for use in sports medicine or musculoskeletal injury and hair transplant. And hair transplant is one of the hottest areas where PRP is now used left, right, and center. So if you look at the entire musculoskeletal system altogether, as you can see, from shoulder to wrist to knee to hip to elbow to plantar fasciitis to endoaculitis, people inject PRP left, right, and center. So I will be concentrating on most of the talk on knee osteoarthritis, because to understand what is the evidence, and that's what most of the time we use. So these are all mechanism of action, how PRP works in osteoarthritis. There is 100 mechanisms of actions proposed, but predominantly it helps in regeneration. The matrix helps in regenerate the cartilage, and it has a lot of growth factors, so it causes, sorry, I will go back. It has, as you can see here, it has anti-inflammatory action also. Also it causes proliferation of the cartilage tissue and the osteoblasts. So straight away, let me go to the clinical trials which are there. Then you understand what is the confusion. Then we will try to solve this mystery. So this is one of the first studies which was published way back in 2012. That is around 12 years back, where they randomized 120 patients. Half of them were given PRP and half of them were given hyaluronic acid. And what did they do? They took grade 1 to 3 osteoarthritis, grade 1 to 3 osteoarthritis, and 4 doses of PRP versus hyaluronic acid was given. And as you can see here, the blue bar is the ACP's PRP group, and hyaluronic acid is the red one. The blue line you can very clearly show, it shows is much better than hyaluronic acid, without any doubt. Similar study, which was again published in 2016, they took a slightly larger patient pool, 100 patients, grade 1 to 3 OA. It was a double-blind RCT, and 3 injections were given. As you can see, this is a WOMAC scale or pain scale is the easier to understand, the lower one. As you can see here, the pain scale dipped in both arms, but it was much better with PRP when compared to the hyaluronic acid groups. IKDC score is just the opposite. The IKDC score, the knee score improves, indicate that the patient is improving, unlike the VAS score where we expect the pain to dip. So you can see, and another very important point which we can see from here is that after 6 months, there is increase in pain. So effect of a PRP or hyaluronic acid or whatever is maximum at 6 months. That was another key takeaway from this study. Then this is another study where they have tried, this is a study from PGI Chandigarh, where they have studied PRP versus saline injection. So they took 150 patients, 54 were given single PRP injection, other 50 were given 2 PRP injection, and last 52 were given single saline injection. And as you can see here, the top one, the yellow line on the top is the saline injection, where there was no difference in pain, but in both the group, single PRP or 2 PRP injections, there was a huge dip in the pain, and the effect lasted up to 6 months. So again, it's a sham control, much better evidence when compared to hyaluronic acid. Then people have compared with steroids versus PRP. As you can see, this is very small study around 50 patients, and what their conclusion was, in the patients who were given steroids, the effect was short lasting. Although they improved, the increase in pain was after 4 or 5 months, the pain started increasing in the steroid group, but the PRP, the effect was longer lasting. So there are more than 50-60 randomized controlled trials on PRP. There were quality of studies is debatable. Then there are a lot of meta-analysis has been done. This is one of the earliest meta-analysis which was published in 2013. As you can see here, this is the forest plot, PRP versus hyaluronic acid. They have included around 15 studies here. You can see the pain reduction was much better in PRP when compared to hyaluronic acid. Similarly here, versus corticosteroid, you can see here the PRP, the pain reduction was much better in PRP when compared to control. Same with the sham control studies also. And sham control studies are less when compared to steroids or hyaluronic acid. Look at the WOMAC. If you look at the WOMAC scores also, PRP, all the results, be it against hyaluronic acid, be against corticosteroid, be it against saline, everything was favoring PRP. But the major issue here, which I want you to understand, is that heterogeneity of study. What is heterogeneity? We want the studies to be homogeneous. If you take rheumatoid arthritis studies, you have almost homogeneity is very high. The variability between studies less than 25%. So less than 25% is ideal when we say that homogeneous is all the study sample size is homogeneous. But if you look here, the heterogeneity is 89%, is very, very high. So indicating that studies differ between themselves because of various reasons. I will come to that thing in a couple of moments. And if you look at all these studies are not at all well conducted. Sometimes blinding is an issue, sometimes later PRP preparation is an issue, sometimes how you inject is an issue, sometimes there is a selection bias. There are hundreds of issues with all these studies. That's a major problem. Then this is another, I will just skip this, but I just want you to tell that there are multiple meta-analyses, multiple systematic reviews showing almost similar results in last 4 or 5 years. From 2016 meta-analysis, 2013, 2018, there are multiple very well done meta-analysis, but the problem is same, the heterogeneity between studies is very high, and the PRP preparation and how we administer PRP and how you assess these outcome measures is different between studies. So it is the level of evidence is not very high. Then came to these 2 landmark studies. One was published in JAMA, which in 2021, they randomized 280 patients, 144 were given PRP and 144 were given placebo. So it was a placebo-controlled intraarticular 3 injections of either saline or PRP. What they see, there was no difference. At 2 months or 12 months, there was no difference in pain. Also, there was if they had done MRIs at 12 months, there was no difference. You give PRP, you give saline, there is no difference at all. So that was the major outcome measure. This was a well-publicized study. Most of you must have seen this. So almost similar time or 1 year later, there was another study which was published, Knee Surgery, Sports Traumatology and Arthroscopy 2022. So it was another big study, 600 patients, 300 were given 3 injections of PRP and 300 were given saline injections. So their results were entirely contradictory. What did they see? Look at this. All the p-values are highly significant, be it WOMAC pain, be it stiffness, be it physical function, be it WOMAC total score, all were significantly improved in those who were given PRP at 12 months. And they also did structural modification, MRI. You look at the MRI at 60 months, 5 years, and it was they did MRI for 300, almost 90% of the patients in both the arm at 5 years. That is a remarkable achievement, I think. And as you can see here, the MRI scores were much better in those who were given PRP. And when you are given and they would also show that they aspirated synovial fluid at 12 months. As you can see here, at 6 months, there was decrease in inflammation in the PRP group. So entirely contradicting, very well conducted, both studies are very well conducted, but entirely contradictory results. So then I started looking at why this is happening. So just I want you to look at this. In the first study, in the JAMA paper, what they have used, type of PRP they have used is a commercial product called Regen Lab SA with a single centrifugation. This is Greek and Latin to you now. You will understand at the end of talk now. And in the second study, they have used 2 centrifugations and mean platelet concentration is 4.3 times. So what should you look at when you look at a PRP? So till now what I told is evidence is really messy. Some studies show positive results, some studies show negative results. Why this happens? And this is what happens in your practice also. You must have seen a lot of patients where you give PRP, sometimes it works, sometimes it doesn't work. So as a clinician, what should you do? So this brings us to the second part or most important part of my talk, that what is PRP? So in the whole blood, as you know, there is 93% RBC, 6% platelets and 1% WBC. In PRP, what we do is this decrease the number of RBC to 93 to 5%, deplete it with the RBC and increase the platelet from 6% to 94%. That's all we do in PRP. So how do we do that? Or what we call as PRP, when should we call a platelet-rich plasma? It is very simple. The therapeutically effective concentration of platelets should be in the PRP around 10 lakhs. It should be above 10 lakhs. Then only it is therapeutically effective. And effect is dose dependent. And so because if it is 5, it is less, 7.5 is better, 10 is better, more than 15 inhibits angiogenesis and you should not do. So its effective is 10 to 12 lakhs is effectively you should get. And method of preparation, the biggest problem with PRP preparation is there is no standard methods. There are too many variables. I will touch upon a couple of them. One is how do you take, which gauge of needle you use is extremely important. And how much volume you take is extremely important. 30 cc blood is what you normally take. And which anticoagulant you use is important. ACD is one of the most commonly used and supposed to be the most effective one. And all PRPs are not same. There are multiple variables, be it platelet concentration, how much fibrin concentration, whether leukocyte is there or not, whether it's activated or not. There are a lot of variables. So if you want to understand at least basic, there are two types. One is a pure PRP or leukocyte depleted PRP. Other one is leukocyte rich PRP. So which is better? Always, most of the time, for all our practical purposes, pure PRP or leukocyte depleted PRP is what we should use. And this is very, very important concept. I think as a clinician we should know. The PRP is prepared basically based on single spin or double spin. What is single spin? You just first you spin. This is the single spin does only one spin and separate the PRP. In the double spin, which is more better and gives a better platelet concentration, first spin is you just remove the RBC. You can see here. First spin you just remove the RBC. Second spin is to concentrate the platelets. So you can see here, this is once you spin first time, on the top there will be plasma, then there will be buffy coat and there will be RBC. So from where you suck and remove the top layer is very, very important. And it is a very hand dependent process and you know it's a skillful process. You can see here, you can either aspirate plasma and buffy coat. If you aspirate plasma and buffy coat, you get leukocyte depleted PRP. But if you get aspirate plasma, buffy coat and superficial RBC layer, you get what is called leukocyte rich PRP. And where you aspirate, how you aspirate is extremely important. So, and then after separating this, you spin again, and after the second spin, you activate with calcium chloride. So look at the difference. In the single spin, if you do, the concentration you get is only 1.2 or 1.3. For example, somebody's platelet count is 2, you get a 3.2 lakh concentrate. But you do double spin, you get, and speed is also important. First spin with 1100 and second speed at 2300. You get a 5.33 times. So 2 becomes 10 lakhs. And there are a lot of quality checks. I don't want to bore you, but there are quality checks which are available and there is enough and more literature on this. And you can activate, common activator use is calcium chloride. This is also commercially available. So now let us come to the, just
one more minute.
Sure ma'am. So let us come to the first study and second study, JAMA study and the knee orthopedic study. So what is the difference? You can see here in the first one they have done a single spin. They have spin only one time and mean platelet count they have achieved is 3.25 lakhs. Will it work? It will not. In the second study what they have done manually. They have done 2 centrifugations consequently performed and look at the platelet concentrate they have achieved 8.3 lakhs. Much better than the first study but still it is not optimal and the concentration is 4.3 times. So which one will work? No brainer. Second one will work, that is the difference in the outcome. And ACR has very clearly strongly recommended against PRP. If you look at this recommendation, what will we think? PRP is contraindicated. Why is it contraindicated? It is not because of lack of evidence. It is because the PRP techniques are not standardized. Very clearly mentioned in the literature, it is not well standardized. So what should be, things are very simple. Solution is simple, standardized PRP if you want to use it. And some tips, don't use NSAIDs, don't use steroids. If you have given intraarticular in the last 1 month, don't use PRP because it won't work. And use of tobacco and fever, illness, if somebody has fever, don't use PRP, and tobacco is strictly no during the PRP use. So this is whatever data we had. We had around, done some 200 PRPs in last 3 or 4 years. I just took out my data. Very, very sketchy data we have not maintained because until patient pesters us, we don't give PRP, we negatively counsel them because looking at this data. But some people tell that I need this, then we do. So we have done around grade 2 and grade 3 combined around 100 patients. Efficacy rate, success rate of this is around 50 to 55%, not more than that. But the problem, this is a real life experiment which we did last week. After reading through this, and then I thought we were using some kit. Look at the kit concentration. It is just 2 times. Pre means the patient's platelet count is 2.7. Using the kit, you get a concentration of 5.1. We bought a hood with a negative laminar airflow. Look at the concentration, 8.2. So that is the difference. So how you prepare PRP is the key. And if you use PR, look at this 2.7, 2.5 becomes 5.3 using a kit, but 8.1 using the manual method. And you have to be really, really careful which PRP you are using, how you are using. Take home message is very simple. If prepared properly, it's a useful therapeutic modality in new osteoarthritis, but very, very important, you have to prepare it properly and you have to know the know-how, how you do the PRP, how you prepare your plasma PRP, how much concentration is and how you have activated. Know what you are injecting, and extremely important to have a quality check in place. Just giving a PRP is going to, it's not going to help the patient because of the obvious reasons I stated. Thank you for patient listening.